This conference will now be recorded.
Hello and welcome. Thanks for joining the webinar, Augmenting Delivery of School Health Services Using Telehealth. This is the second session in a three-part webinar series about using telehealth in school health services. My name is Justine Springer, and I'm a program manager at the Maryland Healthcare Commission, an independent regulatory agency whose responsibility includes planning for health system needs and promoting informed decision-making. The Maryland Healthcare Commission serves as a technical resource on expanding use of telehealth in a variety of healthcare settings to improve access and reduce cost of care in the state. We hope that you find the information in this webinar informative, whether your organization currently offers telehealth or is looking to implement telehealth as an alternative to in-person consults in the school setting. Please note that all sessions in this webinar series are being brought to you by the Maryland Healthcare Commission in partnership with the Maryland Association of School Health Nurses. Each of the three sessions have been approved for one continuing nursing education contact hour from the Maryland Nurses Association. Before we begin the presentation, please take a moment to review the activity disclosures on this slide, noting some information about the session and the due date for completing the post-session assessment for one CNE contact hour. More information about how to complete the assessment will be provided at the end of the presentation. During today's presentation, you will learn how innovative uses of school-based telehealth can augment care delivery and meet a range of student needs, and the importance of collaborating with community providers. You will see here listed on the slide the learning objectives, which include explain how telehealth can address gaps in care for students, describe how telehealth can help school nurses meet varying health needs of students, identify tactics for building partnerships and enhancing collaboration with community providers. So now it is my pleasure to introduce our presenter, Dr. Steve North, who is the Medical Director of Healthy Schools, a school-based telehealth program in North Carolina. Dr. North is a practicing family physician and adolescent medicine specialist at a rural health center in Mitchell County, North Carolina. Dr. North founded the Healthy School program in 2011, and the program provides access to acute care, primary care, adolescent medicine, and comprehensive asthma services to over 35,000 students at 80 schools in 6 school districts across North Carolina, and was awarded the American Telemedicine Association's President's Award for Health, Quality, and Innovation in 2014. So now I will turn the presentation over to Dr. North.
Thank you very much, Justine. Thanks for inviting me to be a part of this. The Healthy Schools program has been around for a while, and we are in our 9th year, which is pretty amazing considering when we started in 3 schools and saw about 75 patients. We use 2 family nurse practitioners as our primary providers, and have just brought on board a psychiatric nurse practitioner to support behavioral health services across the spectrum of our sites. As you can see from the map, we're clustered up in the sort of northwestern corner of the state. The Appalachian Trail runs on the north side of these counties, and the Blue Ridge Parkway runs in between the purple and the red dots, and that is Yancey County, Mitchell County, McDowell County, and Burke County. And then down towards the coast in Pender County and Duplin County, we're in our 2nd year of 2 unique partnerships, one with an existing community-based organization that does school-based healthcare, and the other with East Carolina University. So what is it that we do? Well, in 2018, we provided care for over 1,000 kids and teachers in the schools. We drove approximately, our staff drove 17,000 miles to provide support for these programs, And we saved 942 school days by providing care in the schools. Additionally, we allowed school teachers to come back to school for an additional 36 days that they didn't need to miss due to going to see their primary care doc, or they didn't need to get a substitute teacher. Of our 1,000 plus visits, we had 149 surveys returned on patient satisfaction. Those tend to be pretty good, and we use them for program improvement. Additionally, for 181 unique individuals, we worked to connect them with the PCP, help them find medication and resources to pay for it, and additionally provided translation services or some other connection to local community care. And finally, we trained 60 school nurses and other school personnel to present patients with our new equipment. And I think that the presenter is really something that is essential for what we do. We partner with school nurses in every school system, and they know the students better than we ever will. And so working with the nurses to meet their needs of the kids and flex our program to sort of support them is critical to our success and our longevity. So before we move forward, I want to toss out a couple of terms because I often jump around and talk about these, and these are telehealth specific terms. The first is the distance site, which was historically referred to as the hub site, and the provider sits there. And then where the patient sits is the originating site or the spoke site. And in our program, the provider can be one of many people. There's a difference between who the provider can actually be versus who's actually going to get paid. And while a registered dietitian is a spectacular person to have providing care to students to address obesity, in some states they may not be reimbursed for those services because they're delivered via telehealth. I use the term telehealth almost exclusively. Lots of people like to talk about it being teletherapy or telepsychiatry or telenutrition or telespeech. And I tend to talk about the different modalities of treatment that we're delivering via telehealth. The site fee is something that can be charged by the originating site where the patient sits. And under current Medicaid codes in North Carolina, that's about a $20 fee. That could be some added income for a school. However, in North Carolina, none of our school districts have felt that the reimbursement they would receive would justify the expense and the effort to capture that revenue. And finally, the presenter. And for us, that is almost exclusively 92% of the time in 2018-2019 school year, the school nurse. And they operate the equipment. And while the slide says no clinical decision making, I'm going to jump in on that and sort of say they don't have to make clinical decisions. School nurses are a spectacular resource, and compared to having the school secretary present, I, as the provider, am able to gather more information about the patient. We can train folks to take a blood pressure and get height and weight, take a temperature. That's easy. However, when I'm talking with a patient about potentially having strep throat, I'm not going to ask the school secretary to palpate the lymph nodes. However, when it's the school nurse, I absolutely will ask her, and all of our school nurses are women across our 6 counties, and I trust their judgment. They've been palpating lymph nodes for a really long time, and I use that in my medical decision making. So I want to provide you with a brief history of telehealth in schools, because although we've been around for 9 years, we are by no means the originators of this concept. So telehealth has been around really probably since the 1950s. But in 1924, a fellow named Hugo Gernsback, who put out a odd little magazine about technology, proposed the teledactyl, where one could actually palpate a patient at a distance using this device. Telehealth has progressed a long way since this idea of palpation at a distance. And I just find it funny that we're now almost 100 years later, and we are building on ideas that first came into play before the television set was invented. One of the first school-based telehealth programs in the country was at Kansas University Medical Center, and they started in 1998 in approximately 3 schools in Missouri and Kansas to try to address rural access to care issues. They began with a combined model of both medical care and behavioral health services. As the program has grown and changed to meet the needs of the patients and of the schools, they're almost exclusively behavioral health now and serve approximately 150 schools in Missouri and Kansas. And they're definitely the leaders in this field. There was a 2-year program through the University of Kentucky in 2000 and 2001 that connected to 2 schools outside of Lexington, and they were in rural Appalachia. They had a fairly onerous set of equipment with several different monitors and devices to try to treat simple diseases and improve access to care. The program ended not because it wasn't used, but because the expense of maintaining the T1 line was too great for the university to justify continuing it. But it really began to demonstrate the early potential of school-based telehealth. And in 2001, the Healthy Access Program launched at the University of Rochester. Ken McConaughey, who's actually in the bottom left of that picture, and Neil Herendeen, who's up in the top right, were the physicians who came up with this idea and began growing it. They began in daycare centers and elementary schools and have now spread to every school in the city of Rochester, New York. They used a unique model initially of store and forward telehealth, where images and a story were collected where the child was located at the originating site, and a physician or nurse practitioner would review that information later in the day, contact the parents, and prescribe medication. They have evolved into a real-time video model, and one of their great features is that they can connect back to the primary care physician's office about 60% of the time. So those kids are able to see someone in their regular doctor's office as opposed to needing to see someone who is employed by the network. When the primary care office is not available or that primary care office doesn't participate in the Healthy Access Program, they connect to the University of Rochester's resident clinic. The great research in school-based telehealth has historically come out of Ken McConaughey and Neil Herendeen's work. And this is a demonstration that in their program focused on childcare in early elementary school, before the school-based telehealth program was implemented, you see in the blue the number of absences. Afterwards, you see a tremendous deficit or decrease across the entire spectrum of when their disease is more prevalent, January, February, March, with viral URIs and influenza-like illnesses, and then that decrease continued into the summer and on. So they really demonstrated that school-based telehealth has the impact to keep kids in school. Current programs across the country fit into a wide variety of categories, and I think that's one of the important things. What our program does in North Carolina is very different than programs that I'll feature in other parts of the country. And making sure that a school system that's considering partnering and developing this type of program is meeting the needs of their students is what's really important. And that the school nurses are engaged in the conversation from early on, as opposed to having this idea brought to them after implementation and being told that, well, now you need to present these patients as well, on top of the other responsibilities that you have for the health of your students. So advocating for your role in program development is essential. One of the initial ways that school-based telehealth has been used is to add services to existing school-based health centers. And an example of that could be bringing a cardiologist into a existing school-based health center. This is a story about a patient named Sam, who at age 11 was hospitalized due to a hypertensive crisis and some acute renal injury. His family lived about 75 miles away from the children's hospital, and additionally, that's where the pediatric cardiologist was located. They made one follow-up visit because the family had one car, 5 kids, and mom worked a part-time job that didn't allow her the time away. When you drive 70 miles, there's the gas, there's the parking fee, and additionally, you've got to stop for lunch for at least 3 of the kids, and it became a very expensive trip for the family. 2 years later, Sam was able to reconnect through his school-based health center when they had established a relationship with the pediatric cardiology office to use telehealth to deliver specialty care to the school. And what happened then was Sam, who's now in 7th grade, shared that he became much more engaged in his care. He worked with the nurse practitioner who was seeing him. He was able to see a nutritionist as well. And over the course of 4 or 5 months, his BMI dropped from being in the 99th percentile to into the 95th percentile. And while that seems like a very small decrease in actual weight, it has a tremendous impact longitudinally on an adolescent's health. The next way to use telehealth in schools is to expand the reach of existing programs. Out in Eastern North Carolina, the Pender Alliance for Teen Health is actually doing this at 3 bricks and mortar school-based health centers. The provider spends 2 days at one health center doing physicals and other types of care that require in-person care, and then at the same time is able to reach out to the other 2 health centers to provide acute care. And this allows for comprehensive physicals, which is something our program cannot do because we're entirely virtual, but also allows for immunizations and small procedures potentially, and reproductive health services that may or may not be legal in a specific state. And finally, an entirely virtual model. And that's what the Healthy Schools program is. That's what the Healthy Access program is, where we don't actually have a bricks and mortar location within the school and really serve as a partner and at the pleasure of the school and the school nurse. Finally, one of the exciting things that is coming out and growing is school-based dental care via telehealth, where cleanings and screenings are done in the schools. There are a couple of great programs. One is the virtual dental clinic in Colorado, and that's getting the majority of the attention. And there's a community health center in Salud, Colorado, that reaches out to their local schools. But the goal is to do the preventive work at the school so that when a student is identified with dental caries and they come to the dental clinic, the time is more efficiently spent. And so the dentist knows that they've reviewed the films and reviewed the remote x-rays, and they know that they need to focus on teeth 5 and 12, and that the rest of the teeth have already been addressed and are in good shape. This has really been demonstrated to improve access to care and decrease some absences from schools on an anecdotal basis. One of the programs that I really like is in Sioux Falls, South Dakota, sponsored by Avera Health. And Avera Health is a large health system that is funded by the Helmsley Charitable Trust. And you may remember Leona Helmsley, the hotel baroness in New York City who famously left her fortune to her dog. But her husband had set up this family trust, to benefit innovation in healthcare in South Dakota and beyond. And so the challenge that this addressed was that school nurses realized that there were students who had issues with type 1 diabetes and that they were not able to get insulin at schools because the nurse could not observe the delivery. And so this is where the program started. And Sheila Freed began development of this program about 5 years ago. And what has occurred is that now, at a rural school, a trained professional who is unlicensed is able to administer the insulin under the observation of the school nurse who's seeing that student virtually. From there, the program has grown to now bring all school nursing services to the schools when the school nurse is not there, allowing them to evaluate students, allowing them to make the referrals, recommend Tylenol or ibuprofen as needed, and keep kids in class. In North Carolina and in many other rural states, there are very few schools that are fortunate to have a full-time school nurse. And so this spreads the reach of the school nurses, so they're spending less time driving between one school and to the next, and are really able to do a better job of caring for all of the students who are their responsibility. And Avera has just announced as of yesterday that they're working to spread this across the upper Midwest and Great Plains through their 7-state telehealth network. So it's going to be fascinating to watch that program grow. Everybody likes to ask, well, does it work? And school-based telehealth works on sort of a personal level and on a student-by-student level. But one of the questions is, does this work on scale? And are we really working on a sustainable model that makes an impact on academic outcomes? And the answer is we're not sure yet. We do know from, this is one of the favorite stories of Mark Garrett, who's the superintendent in one of the school districts that we serve. He talks about the fact that if you're a kindergartner and you begin missing a day per month, which most parents don't see as a big deal, you miss 10 days a year. And after 13 years of school, you've missed 130 days, which is almost the equivalent of an entire school year. And chronic absenteeism is a huge issue that impacts academic outcomes and is probably a marker for a depression, anxiety, or another behavioral health issue that students are wrestling with. We know anecdotally that the high utilizers and the chronic absenteeism students in our network have decreased because now the stomach ache that occurred every Tuesday morning before the spelling test, resulting in a trip home and a day out of school, is able to be addressed more effectively, reassurance provided, and eventually that student stops coming to the nurse and takes the spelling test as scheduled. When we think about health and academics together, graduating for high school increases the life expectancy of people by at least 7 years, and that is general population numbers from an article in Health Affairs in 2016. So high school graduation as a health indicator is something that needs to be promoted more, and having school-based telehealth services to enhance what school nurses are already doing can help impact that through obesity prevention and treatment, and also through blood pressure control. However, in our model, we're not sustainable in a fee-for-service environment. We know that even in our busiest, we're only going to see about 20 kids per day. That's all the slots that we have. And we make $50 per visit, and once you count vacations and snow days and testing days when no students come to be seen, we only generate, our maximum potential revenue is about $160,000 a year. Therefore, I don't see this as a sustainable product in a fee-for-service environment. And that's where looking at the ways that this enhances the quality of care provided by school nurses and the academic outcomes for students is so important. We also know that the average U.S. child only goes to the doctor 1.6 times per year. And more visits to the school-based health center or to the school nurse may indicate that something more is going on. And so how do we incorporate prevention and also screening for depression, anxiety, and risk-taking behaviors into what we do? I think that that's an important part of early identification of issues that will have a longitudinal impact on a student. And by partnering with a school-based telehealth program, you have the ability to bring more expertise to the school or help connect students to expertise within the school and that they may not get connected to otherwise without a nurse practitioner or physician saying, I really think the school counselor or the school psychologist needs to take another look at the kid. And then we talk about the future and where is this headed? Because I see a lot of potential for the use of telehealth in schools for enhancing so many aspects. One of the problems I end up with is that, like the Kool-Aid man says here, people think that, we're just there to do acute care. And I really think that we're there to do so much more. And the potential exists to grow programs to meet the needs of specific schools. And that's where building partnerships and communities is essential. As I think about the ways that we can partner to create healthier students through virtual care, I created this model because we can address everything from connecting kids for vaccinations and providing behavioral health services to treating concussions and evaluating them via telehealth with the goal of keeping students healthy so that they stay in class and they do well academically. I think that we're really at a time when we can move the care of students to the most appropriate environment. I am not saying by any means that all care for an adolescent should be provided virtually. I feel that there's still a very important relationship with a family doctor or a pediatrician over time. What I am saying is that we can change how we provide traditional face-to-face care, and that we can incorporate virtual health technologies, whether they be looking at ears through an otoscope in the school nurse's office and diagnosing an otitis media, getting that child on antibiotics before 3 o'clock in the afternoon so that if they're afebrile, they can return to school, or gamifying education around healthy eating and using that as a way to encourage healthier behaviors and more physical activity. But I really think that we need to move towards an idea of care being provided wherever it's most appropriate and easiest to deliver, and also has the least impact or provides the least level of inconvenience for families. One of the ways that I think about this is the integrated behavioral health pipeline. Frequently what happens in a school is that the teacher raises a concern, and unfortunately, they say, you need to talk to your doctor about this. And for my patients where parents are working 2 jobs to make ends meet, coming to get in to see me can be a huge burden for them, coming to see anyone in our practice. And so the child's issues with depression or inattention or vision problems are not appropriately addressed. But if we can take that concern from a teacher and do an evaluation either in person or virtually so that the depression can be evaluated and a PHQ-9 can be administered, and then therapy can be provided for the student and they can feel better about themselves and focus more on their classroom because the inattention part of the depression is decreased, that's spectacular. And if medication is needed, we can provide the medication to the student. And finally, as the student has improved and may not need weekly therapy sessions, we could use a virtual check-in system to provide ongoing support. And when a student hits another bump in a road, they can come back for more intensive therapy at school, and they can have their medications adjusted by a psychiatrist or a family doctor. So there are a lot of options out there as to how we can use virtual care to meet the needs of our students. So what I'd like to see happen with a student like Sam down the road is that via telehealth at school, we can manage his blood pressure, provide dietary counseling. He could be seen by a physical therapist or a sports medicine doc for rehab of his sprained ankle, and we can take care of his risk screening. We can do an annual screening around depression and healthy choices, and also around substance use, to see if he needs more support. Connecting with the primary care physician to provide healthy adolescent care, the comprehensive physical that is not what a sports physical is, to provide immunization, and to begin addressing transitions in care. How that at age 14, your mom may be driving the majority of your health care, but how when you're 18, 19, and 20, do you have the skills to drive that care? So how do you build a program? How do you say, gosh, this sounds like a great thing? I heard the talk from Kelly Garber that was recorded earlier, and I heard about the program here in Maryland. Clearly, this is what we need at our school. And this is where you need to move beyond just a great idea. And I want to give you some advice about what we have found to be successful. And my colleague Amanda Martin does a large amount of consulting across the country on building programs. One of the first things you need to ask is, will it? Will this program, first and foremost, be ethical? Is it appropriate to provide health care at schools for kids, at a place where they can access it? Obviously, I feel we should be able to do that. And I feel that it's not only ethical, but we know that it's important to changing drivers of health to provide increased access to care. And the school is where kids spend the majority of their time outside of their home. The other thing about being ethical is that I feel that it needs to be available to all students, regardless of their ability to pay. That setting up a for-profit entity that only happens if you can swipe mom or dad's credit card really changes the dynamics within the school, but also doesn't help those students who need the services the most. The next question that often comes up is, will this be legal? And that happens on a wide variety of levels. Can you actually provide health care in the schools? And I know that in Maryland you absolutely can, that there are no laws preventing that. The second question that often comes up is from school district side is, well, what about malpractice? And school nurses become concerned about that because they're the presenter and is their license at risk? And the malpractice and liability is entirely upon the provider at the distant site. Our organization holds us a entirely separate malpractice policy for our providers that is not dependent upon the schools in any way whatsoever. It's part of the cost of us doing business. The next question is, will this be legal? Will it benefit our students? And if so, how? How are we going to think about that? How are we going to measure it? Or is this program something that one person felt that we needed to provide genetic counseling in the schools, and now we've been asked to put in all this equipment and time, and the need for genetic counseling in our school is limited? Maybe what your school really needs more than anything else is a behavioral health person to address the risks of vaping and help kids who are wrestling with that addiction. And they may not need someone to provide acute care because kids can easily get to their primary care docs, but there's nobody in the community talking about vaping. So designing the program to improve the services that students are able to access in the community is essential. What's the benefit to you as a school nurse? We're asking you to do something more. And some of the school nurses we've worked with have pushed back against that concept. You're asking me to do more. And then over time, they begin to realize that they're spending the same amount of time with a student who they identify as having a health issue that needs to be addressed by someone outside of the school, whether they present the student via telehealth or if they are calling the parent and trying to arrange the ride and getting the notes written and then figuring out when the student come back to school. Our average visit from start to finish for the nurse takes about 14 minutes. Our school nurses are presenting maybe one patient a day 3 times a week. So this is not a request that all of a sudden you're in a primary care practice. When I see students for behavioral health issues, for med management, I frequently see them somewhere other than in the school nurse office in a quiet and enclosed space, and the laptop is just moved there so that we can have a conversation about their medication. After the vital signs are taken, the school nurse's role is done. I will let them know what we've done. I'll let the primary care physician know within 24 hours if I've made changes in medications. I will talk to the parent, but really, I'm not asking the school nurse to sit in that half-hour conversation about risk-taking behaviors because of anxiety. And is it going to change your role? And does it move you from the population health and student health role into a role of being just somebody who presents on camera, losing some of your independence as a provider? And I feel that if this is done well, it does not. Yvonne Harden, one of the school nurses who has been working with our program in Yancey County since its inception in 2011, says that she was a little skeptical at first. Some of her colleagues were afraid we were going to take their jobs. But then she realized that we're just providing her with another tool to use with students. We're not asking her to give up all the care that she provides because these are her students, and we're just working to help them get improved access. In building a program, you've got to think about the relationships and who is going to champion this. First, from a school nurse perspective, does your school have the capacity to do this? Or are you a school nurse who has been spread across 5 schools of 250 kids each, and unfortunately, you don't have the ability to get your asthma action plans all filed before Thanksgiving? Maybe you're not at a point yet where you could bring this in, because it will add a little bit of a time on a presenting student basis, but more importantly, the development process is going to be a challenge. What are family expectations in your community about providing care at school? When we began exploring the possibility of developing a school-based telehealth network in Coeur d'Alene, Idaho, we had been contacted by a local school nurse who was working on her doctorate in nursing practice. We said, great. And the first thing we did was a survey of parents to see if there was a need. And most of the time, 90% of parents say they definitely will or probably will have their students use the school-based telehealth network. And only about 10% of parents say definitely won't or probably won't. In Coeur d'Alene, Idaho, 25% of parents said that they definitely would not or probably would not use the services, and put comments in like, keep the government and the school out of my kid's lunchbox and out of my kid's health care. And it was a very different environment. And so making sure that you're not disrupting your school system more, disrupting your community more, and gently bring this idea forward is really important as well. And finally, relationships with providers in the community. Are you partnering with a local provider, which I think would be ideal, but I live in a rural community filled with federally qualified health centers, and to get in to see us acutely is really difficult. And I don't have the slots in my clinical practice to say, yeah, I can see Johnny at school. When we were developing our program, we met with all of our local providers in Mitchell and Yancey County, and one of the physicians said, well, the school's just a half mile away. If they had a kid who needed to be seen, I could just drive right up there. She's been in the practice for 20 years, and I asked, well, Liz, have you ever done that? She said, well, no, because I've got patients to see in the office, and our schedules are full. So do you use local providers who are able to think about this in a way to integrate into their own schedule, or do you need to find a new provider pool that is able to provide the service and be a consistent individual? I think that's an important thing to think about with providers. Our school nurses love the fact that there are only 3 of us who see patients through the network, and 95% of the patients receive care from either Tanya or Meredith, our two nurse practitioners. And so a rhythm and a pattern develops, and the school nurses become comfortable calling and asking questions even when they don't have a patient to present. And those relationships, I think, are critical to provide. There are definitely some regulatory issues that historically have existed and may still exist, whether it be local school district policies around when a student needs to go home. Does a student need to go home every time one of their eyes is watery and matted? Is that allergic conjunctivitis because grandma just got a new cat? Or is it actually pink eye? And now that you have increased ability to diagnose and potentially treat, do you have to change some of your regulatory patterns in the school system? There are also regulatory issues at the state level around who can see kids in schools or via telehealth in general. And Maryland's relatively progressive on this front compared to North Carolina. Finally, there's the financial aspect. Who's going to support this program? Who's going to pay for the school nurse's time? Who's going to pay for the internet connection? And we've been fortunate that in our program, we provide a little continuing medical education or continuing nursing education for the school nurses and have developed a noon lunch program once a month that provides a half of a CEU. And that is how we're compensating the school system for the time. I know in other places this has become a sticking point and has prevented programs from developing. So how do you measure success? And how do you prove that what you're doing is a good thing? Well, we use some common pediatric ACO measures to think about what we're doing. And we're trying more to partner with insurers who have this big picture of where kids are receiving care. Because it's very hard for us to tell if a student who we began asthma medication on Thursday to prevent an exacerbation, were they seen in the emergency room over the weekend or not? And in a larger health system, we may be able to do that. But by partnering with insurance companies who are actually seeing where their dollars are spent, that's the way to get some of this data. And then risk screening. This is a great opportunity to do a simple risk screening in school. There are a couple of online tools that can be used and address that. And that is becoming an important ACO measure for both primary care docs and community-based organizations. We feel that we can help decrease inappropriate use of antibiotics by seeing kids more frequently. The potential exists to see kids for ADHD medication follow-up, and also for BMI evaluation and education on how to maintain their current weight while they grow taller or to lose weight when appropriate. And I think that one of the keys for sustainability for any type of a school-based virtual care program or telehealth program is to develop strong relationships with ACOs and primary care and patient-centered medical homes. So how do you enhance access? And how do you identify those students who are being seen that don't have a primary care physician? How do you connect them to a medical home? And how do you track care and coordinate? I think that's one of the really important things that happens. Too often, a school nurse will identify a problem with the student and send them to the doctor, and the student gets a bunch of treatment and may go see specialists, but the school nurse, because of HIPAA and other issues, may never have that loop closed to know if Johnny's vision was addressed. And I think that that's really, really important. And how do you build this stuff into a program? How do you build the communication in so that you're not reinventing the wheel every day with every student? Technology changes rapidly. This is an old tricorder from Star Trek, and at one point in time, a gentleman out of Chicago attempted to develop and sell a tricorder for home use, and the federal government and the FDA, specifically the FDA, fined him millions of dollars for that. Don't start thinking about technology until you've developed your program. Technology is developing so quickly that what we at one point needed a $20,000 cart to do in year one of our program, now in year 9, we are spending about $2,000 to equip a school. Make sure that what you do choose can grow with you. So if you're starting with a behavioral health program, can you just begin with laptops or tablets that eventually, if you wanted to add acute care, you could connect peripheral devices to? Too often when people contact us, they say, well, I really just want to know what kind of technology you use. And in telehealth across the board, the technology is really the easy part. It's working out workflows, relationships, and understanding scope of care that's really important. So thinking about equipment, how do you choose your equipment? Well, first, what are you trying to do? Are you trying to just do behavioral health, or do you want to do the full scope of care and be able to listen to hearts and lungs and be able to take pictures of rashes to send to dermatologists, or to be able to look at 48 hours later to see if they have improved? What's the patient experience like? Do they have to have all these wires wrapped around them to be seen? And more importantly, what's your experience as a nurse like in trying to flip this on? Do you have to start up 3 different computer programs and a television set and a laptop for the patient to be seen? Which is how our earliest program worked, and we've evolved our technology 4 times in the last 9 years. Or is it a simple integrated device or a single laptop with an easy sign-on? Do you have access to an electronic health record? And if so, is that the same electronic health record that the provider at the other end is using? Very rarely does that seem to happen. Dallas Children's is the only program that I know of where the school nurses are directly entering information into the student's electronic health record at Dallas Children's Hospital. And who controls the system? What are the protocols in place? And finally, are you buying the equipment outright, or do you have a lease agreement where at the end of a 6-month period, you can turn it back in if it didn't work, if you're not achieving what you wanted? I'm going to get on my soapbox for a moment. Some of these things I've mentioned and others I have not. Number 1, design your program first before you choose any of your technology. Then work with your school system to find what technology is going to work best, and work with your healthcare provider to see if they already have a system that they're using that they can easily connect you to. 2, you need to see inside the ear to diagnose otitis media. Don't sign up with a program that says that we don't need to look in the ears to diagnose an ear infection. That's poor quality care for your students, and they deserve better. And finally, remember that time is finite. Just because you have access to a provider via telehealth doesn't mean that they're going to be able to see every kid the moment they need to be seen. You may be spread between 2 schools, and you're not going to be able to be there. This is one way to help improve access to care, but it will not answer all of the needs of students in schools. So there's a group of us that's been working on best practices in school-based telehealth. Medical University of South Carolina, University of Rochester, our practice, Dallas Children's Hospital, and others. And I think that these are the key points to take away. The first is access for all students. You need to see everybody to really have an impact on academic outcomes. Be part of the school community. Don't just have a program that is sitting outside and you're adding a layer. Take referrals from the schools and make sure that the provider you're partnering with is willing to give school nurses continuing education or help answer questions even in situations where they're not able to bill for the visit. If a student's been seen through a telehealth program, who do they contact at 7:30 at night when the prescription didn't make it to the pharmacy or things worsen? How does that work? Make sure that all information gets back to the patient-centered medical home. School-based telehealth programs should not be trying to take patients out of patient-centered medical home environments. Train presenters, make sure that they're comfortable with what they're doing, they know the technology, and they know what to do when it doesn't work. And if it doesn't work, or a student is too sick or has an issue that can't be addressed through telehealth, make sure that you have a backup plan. The ingrown toenail with cellulitis partially can be treated via telehealth. We can see it, we can start the antibiotic, but it really needs to be removed. And that requires a relationship with a family doc or pediatrician who's willing to get the kid in once that infection is calmed down and remove it. And finally, help students connect. The program should be helping students connect with primary care physicians and should be referring students for well child checks. So how do you evaluate the success of a program? So what should programs measure and why is one of those questions that often comes up. Well, measuring health outcomes is clearly important. We want to look at disease management. We want to look at improved screening rates, BMI, mental health, hypertension, and do those students receive follow-up? That's the easy one. The second area, because we're providing care in schools, is what does this do on attendance? And what is the impact of academic advancement of students? If we're able to decrease the number of days that a kid with chronic absenteeism has, maybe they're not just socially promoted into fifth grade. Hopefully they've covered the academic content to become a successful fifth grader. How do we look at those things, and how do you partner with the school system to get that data? What's the impact on families? The majority of the kids that we see are on Medicaid or are uninsured. 13% of our kids did not have any health insurance last year. And folks who don't have employer-sponsored health insurance, and even those that do, often have fairly onerous requirements for taking time away from work. And to leave work for a half day to take your kid to the doctor may have a negative impact on your ability for a promotion, but also mean that you can't take the week off next summer because you've lost the points and hours. When you talk about partnering with a health system or a provider group, talk to them about how you're going to look at downstream impact of seeing kids and connecting them with care so that the well child checks, the immunizations, the ancillary services can all be driven through their offices. And so that the physical therapy referrals increase the hospital system. Are we creating revenue for a health system? Perhaps. Keeping kids out of the emergency room, unfortunately, in a fee-for-service environment, does not increase revenue for the health system. But it is a more appropriate location of care to provide that care in the school for otitis media than to have that seen in the emergency room at 8 o'clock at night. And that sometimes is a pushback that people get. Well, you're actually costing us money because you're taking kids out of our ED. So you need to look at the overall cost of care on the health system as a whole. Evaluate how much collaboration you have. Who are your partners, and have you become part of the patient-centered medical community? And finally, what is satisfaction of the program? Would patients and families recommend us? That's what I get evaluated on by my health system for my day job is, are we going to recommend you to be seen as a provider to our friends? Not, did you prescribe the right antibiotics? And also, are your collaborating partners happy with what you've accomplished and that you're a good partner to work with? 2016, there was a large grant program for development of school-based telehealth programs. Out of this, 189 new sites were created, 21 new networks, or 21 networks either were expanded or were created. From this work, there's come a variety of evaluation domains for school-based telehealth programs. And they fit in both the clinical realm and the operational realm. And these scales and tools are readily available for you to use to evaluate your own programs or to partner with someone getting their master's in public health who needs a project to evaluate what you're doing. Finally, there's a collaboration between the School-Based Health Alliance, the Mid-Atlantic Telehealth Resource Center, of which Maryland's a part, and our organization to develop a Center of Excellence for school-based telehealth. The Center of Excellence will launch in January of this year, of 2020, if everything stays on track. But at this time, there's a telehealth in schools discussion available on the MATRC website, and would recommend that you check that out. Post questions because people are more likely to respond to questions that are posted than to post new information de novo. Finally, the model, once again, of sort of where I see this being able to progress. And please feel free to reach out to me, and I think Justine will share contact information later. Thank you.
Thank you, Dr. North. That's very interesting. So just want to ask you a few questions really quickly here. So our first question is, how effective has school-based telehealth been in addressing gaps for care for students in North Carolina?
Although there are multiple school-based telehealth programs in the state doing different types of care, most being the delivery of behavioral health services to schools, we're seeing anecdotal or small sets of evidence that we're improving the access to care, improved numbers on PHQ-9s, and improved control of depression. But we don't have the resources at this time to do a statewide study on our impact on healthcare in general. So where school-based telehealth programs exist, for the issues that they're targeting, whether it be behavioral health or access to acute care, they're making a difference. But we don't have the ability yet to measure that in aggregate across the state. I know that's not a great answer, and I'm sorry. Yeah.
Well, thank you for the information. Very informative. So another question I had was, how has telehealth assisted school nurses in meeting a wide variety of student needs?
Well, I think that it's done a couple of things. And the first and obvious one is that students who have needs are seen urgently, seen in the same day for things that they may otherwise have left school for. And that's great because we help the students stay in school. Our program has a local program coordinator, and one of their roles is to take on a case management role. We have the resources to go and purchase a course of antibiotics and an albuterol inhaler for a student to keep them out of the emergency department and get them back to school sooner. Additionally, our program directors work to connect with local resources. So if the family is struggling with housing, they can help address that and take those responsibilities off of the school nurse so that she can provide care to more students in the school. Because I know that school nurses at times become the de facto social worker and health educator and everything else. And so through our program, we can help with that some, but I think that's important.
Great, thank you. And then just one last question. How has school-based telehealth evolved to enhance collaboration with community providers?
Yeah, so the Rochester model that I mentioned in the sort of historic models has always focused on having the community-based provider provide that care. There's some restrictions around that in the rural communities where we work because Medicaid and Medicare in North Carolina will not reimburse federally qualified health centers and rural health centers to be the distant site in an encounter. They aren't able to take the lead on this, and they aren't able to see their own patients. And that's one of the reasons that we have a group of nurse practitioners who provide the care. However, what we are able to do is, A, find kids who have not been seen for a well child check and get them back into care. B, help establish a patient with a provider when they don't have one. And C, this is still in its infancy, 9 years in, we haven't gotten a lot of traction because we still live in a fee-for-service environment. What I would love to see is that the student who started on new asthma medications on the first of the month is able to do their follow-up through a school-based telehealth program on the 15th of the month to see if the asthma medications are having an impact. And that could either be with their community-based provider or with one of our nurse practitioners. We're not there yet. It's happened a couple of times. But that's where I really see the potential for this.
Great, thank you so much for the additional information. So
Absolutely.
thank you. So on behalf of the Maryland Healthcare Commission and the Maryland Association of School Health Nurses, we appreciate Dr. North's presentation, and for everyone who attended Augmenting Delivery of School Health Services using Telehealth. We hope you found the information to be valuable. As Dr. North mentioned, we have his contact information here on this slide should you have any follow-up questions about the great work he and his team are doing in rural North Carolina schools. So before we conclude, I just wanted to give a quick note about how to get your C&E credit for attending this webinar. You must complete the post-session assessment, which can be accessed at the link, which is located right below this video on the YouTube session webpage. An answer must be provided for all questions noted with an asterisk. And please keep a lookout for a certificate of completion that will be sent from my email, which you see on the slide. And if you have any questions about the post-session assessment or anything else about this webinar series, please feel free to contact me. Thank you very much, and thank you to our presenter and for tuning into our webinar.